Hello, my name is Noah Whitaker, and for the last 6 years I've had the honor of coordinating the Tulare and Kings County's Suicide Prevention Task Force. You've already heard a little bit about our early history. Now I'm going to talk to you about our intermediate history to our present. I'll speak about our strategy, our structure, and some of our innovation. But before that, I wanted to talk to you about our branding. You might have already noticed the use of the sunflower on most all of our materials. It's present on our website, it's present on our Facebook page, on our handouts, on our sunflower seed packets. We use the sunflower extensively in all of our efforts to brand suicide prevention. Now this is important because suicide prevention isn't normally branded, but branding provides a symbol and a connection to those that you're trying to reach. It provides an opportunity to give communication, an understanding, and an interaction with your community. The sunflower was selected not only because of our agricultural roots being in Central California, having a highly agricultural and rural community. The sunflower connects with that agricultural base, but it was also selected for deeply personal reasons. I grew up in the floral industry. My grandfather was a florist, my father was a florist, and for a time, I was a florist. Before I was born, I lost my grandfather to suicide. While I was in high school, I lost my father to suicide. The sunflower is deeply personal to me. The sunflower is also deeply personal to Carla, who lost her son Bo to suicide. Sunflowers were Bo's favorite flower. Both Carla and I have sunflowers all over our homes now as a result not only of our work, but also our passion for this beautiful plant. The sunflower is also the perfect symbol for suicide prevention efforts. One tiny seed, when planted, nurtured, given water and sunlight, can grow into a gorgeous plant. That plant filled with other seeds. Those seeds providing prosperity and growth for countless other plants. From one seed, you can plant an entire field with just a little bit of time. This is an excellent symbol for suicide prevention, because with suicide prevention, we're looking for those seeds. Seeds that have lost their way, seeds that need some nurturing, some tending, and some care. And with those things, they can flourish and beautify an entire community. Now, our efforts also come from Proposition 63, which is more commonly known as the Mental Health Services Act and was a voter proposition passed in 2004. The Mental Health Services Act came with a strategy that must be used in providing services. The Mental Health Services Act is divided into different components, and that's a conversation for perhaps a different day. But I'm going to focus on the basic model and the prevention and early intervention components through which we receive our funding. The Mental Health Services Act set a framework for each county to then develop a plan identifying community needs, programs, and implementing them. In our community, suicide prevention was viewed as an essential component that was missing and that we needed in our community. Under this model, you can see that there are universal efforts, there are selective efforts, and there are early intervention efforts. The treatment and recovery portion is for a different component of the Mental Health Services Act. So we're just going to focus on that first portion. Now, when you look at a standard intervention model, you see that about 80% of the population falls into this universal category. These are folks that may or may not have risk factors. They might have, in fact, critical risk factors, but the real standpoint here is a broad-based message that connects with as many people as possible so that you can position your information, resources, and strategies to intervene. These efforts are things like our comic book, our Festival of Hope, and many of our training programs. At the next step, you have selected efforts. Now, selected efforts come with identification characteristics that have some sort of an intervention associated with it. The LOSS team that we've developed with Dr. Frank Campbell is an excellent example of this selected model. It's a program for survivors of suicide loss that we know through research have an increased chance of suicide risk, though at the present time they might not be expressing suicidality. So this is a specific program for a selected subpopulation that we're offering interventions and programs for. Now the targeted level, these are very specific interventions that are usually on a one-on-one basis. There is a program and an evidence base to those interventions, and they need a higher level of support. In our suicide prevention efforts, we have programs for each of these three tiers. Now the next thing that we'll take a look at is the context of the individual in the community and this interaction at various levels. Now this is important because when a lot of programs are built, they're thinking solely of an individual or they're thinking solely of a population-based intervention. But they forget that an individual does not exist within a vacuum. The individual exists with interpersonal relationships, with organizational relationships, with community relationships, and is impacted and can impact policy, such as Proposition 63. So when you're thinking about your programs and your efforts, keep in mind these various layers of society and these various layers that wrap around an individual, because you need to address communication in each of these different spheres. Now we'll take a look at what I call a typical treatment team. You could find these in mental health or behavioral health care providers all across the country. They're typically led by a psychiatrist, psychologist, or other mental health care professional. They have supports from therapists and RNs. They typically will have case managers, substance abuse specialists, or psychiatric technicians, or similar paraprofessionals, and they'll be supported by a secretary or receptionist. These teams are sort of more common teams, and a lot of the time are what people try and achieve when they're lacking these sorts of supports. Now, one thing about these teams is they tend to be very expensive. So when we took a look in our community at how to best approach suicide prevention, we determined that if we developed a small team of professionals that's highly trained, that it actually wouldn't reach more people in our community that were at risk, because it would have greater challenges of finding those people, getting information to them, interacting with them, and it would cut off the sort of and underserved populations. So we decided to go with a broader-based model. Now, when you look at mental health services, here's sort of a collection of some of the standard areas and locations in which these services are delivered and received. Now, some of them are what people would consider or call ideal, such as in a clinic, a primary care setting, or from a private practitioner. But realistically, mental health services are provided in a variety of venues. More and more, they're provided in public schools and private schools. One of the major activities of any first responder, namely law enforcement, is interaction with those that have mental illness. If you're familiar with statistics in the prison population and how many of the prisoners have a mental illness, you'll know that prisons are a very large place that either provide mental health services or have dire need for them. Now, spiritual centers are also where people go for mental health services. They might not put them in that context, as the spiritual realm is important as well to get a holistic approach for support and intervention. But really, if you look at it too, if you've browsed Amazon or been to a bookstore, if you can find one, you'll see that the self-help sections are really large. So that's another area that's important to not miss or to not set aside, because people are going there for services. Now, if you think about that team that we just took a look at, the typical team, would you see that typical team in any of these other settings, or pretty much just in a clinic or private practice setting? However, services are being delivered in all of the rest of these settings. So that's part of the approach that we've taken. Now, if we look at a model that incorporates both social networks and institutions, you'll see that there's a tremendous amount of opportunity for intervention. Here, if we look at the government clinics, you have the physical space represented in the dot on the far right, or I guess your left. I've color-coded it to try and match individuals to some of these institutions, just as an example. So the curly-haired individual that you see next to that institution, we'll consider that to be a case manager. Now the person at the bottom, who's in red, we'll consider that person to be at risk for suicide. Now if you look, there's no direct link or connection between that individual who's at risk and that case manager or therapist working for the government institution. So how then do you effectively intervene? Do you effectively get word and resources out there? And in fact, what if that person doesn't need to receive services from that government institution or that private practice clinician? So we use broad-based training and other interventions as well as specified training. We've offered things such as QPR, ASSIST, RRSR, CISM, and a variety of other trainings. Now the benefit of that is the individual in orange that's almost in the center, well, that person has been ASSIST trained. And while they don't have a direct link to the individual who's suicidal, they're one link closer. And that person also knows the government worker. So that individual who's received training through our efforts is able to connect that individual to some of the other resources that are necessary. Now, as mentioned, we've provided a lot of different kinds of training, and that's really one of our main strategic approaches, is we'll find training that's appropriate for different segments of the community, give them the best training that we can, and allow them to do their job and be a resource for individuals in the community. One of the main sort of points of ASSIST is that people don't always need to go to a psychiatrist or a psychologist. You need to listen to what their specific needs are and link them with those specific resources. That's really how our task force functions. We have a lot of members from a lot of different segments of the community who work together to save the lives of suicidal individuals. Now, when we take a look at our structure, we need to look at our voting membership. Back when I was assigned to work with the task force, we had no formal structure whatsoever. So one of the first things that I set out to do was to look at this broad-based community approach to suicide prevention and to develop a framework and a model that would support that approach. If you look now, we currently have 21 different voting members, and those 21 different voting members cover a broad range of our society. We do have mental health that participate. We have law enforcement. We also have faith-based organizations. We have our lesbian and gay community present. We have individuals that are from our aging and adult services. We have a representative from our medical society. We have 21 different members from different segments in our community so that we're not homogenous. We do have a shared goal and we have a shared vision, but we have different backgrounds and we have different constituents that we represent. This is one of the greatest strengths of the task force, that so many different individuals from so many different walks of life in our community can come together, working together with a common shared goal. We do still have our different interests and we have our different objectives. However, for this issue, we can set those things aside and we can work together. So if you haven't structured or you're looking at the structure of your current efforts, you might take that into consideration to really step outside of the bounds of your norm and to embrace some of these other alternative individuals in the community that you might not have thought to work together with. We've worked together with tattoo artists, graffiti artists. We've worked with individuals from multiple segments of our society. We've worked with beauty schools. We've worked with a psych tech program. We've worked with primary care practitioners and a very, very broad range of others. One of our major standpoints is that in any community, any member of your community can be at risk for suicide. So why try a narrow, focused approach when you can broaden that and create a safety net for the entire community? The beautiful thing about that is since we're looking at diffusing some of the things that contribute to suicide risk, we're simply bettering our community by having, say, a better coordinated system for domestic violence. Those are some of the recursive benefits that come from this broader community-based approach. That not only are we making this a suicide-safer community, we're also just plain making this a better community.